Today, the topic of discussion is approach to anemia based on automated hemogram. What you need is a drop of blood that has to be subjected to Coulter counter and it will give you a printed report like this. And what does this printed report? Look at this. This is the printed report. What are all the parameters? This is the three-part counter. In three-part counter, your WBC will be given as neutrophil, basophil, will be given as neutrophil, lymphocyte, and mixed. Mixed contain monocyte, eosinophil, and basophil. Right. So what are all the parameters you can have? What are all the parameters you can have in this printed format? The first one is WBC. Look at this WBC. You can have a total count. Here it is roughly around 8000 cells per cubic millimeter. You can have a lymphocyte percentage, neutrophil and mixed. So lymphocyte percentage, mixed and neutrophil percentage. Here the lymphocyte is 90%. So 90 divided by 100 into 8000. So what is the absolute lymphocyte count? Absolute lymphocyte count is somewhere around, what is the total count? What is the total count? Let me say once again. So where is the total count? WBC 8000. Okay, wow. So this is 7200 cells per cubic millimeter. And neutrophil cannot be read. Cannot be read. So here the total count is 8000. Your neutrophil is, the lymphocyte is 7200 cells per cubic millimeter. If neutrophils are shown, you can calculate. So let me say if neutrophil is 10% means, let me say 10 by 100 into 8000. So how much does it come around? Somewhere around 800 cells per cubic millimeter. So WBC parameters are total count, absolute lymphocyte count and absolute neutrophil count. Now, what is the RBC count? What is the RBC count? So the RBC number, the hemoglobin, the hematocrit as well as MCV. What are all the things that should be given in RBC parameters? The things that should be given in RBC parameters are, one is RBC number. Here it is 1.7 million. Second one is hemoglobin. Here it is 6 gram. Normally it should be somewhere around 10 gram. For roughly we can say 10 gram hemoglobin. MCV is somewhere around 7. It should be between 70 to 90. What is RDW, red cell distribution width? You have two values. One is ST value, another is CV value. You need to use CV value. CV value here is 25. What are all the things that should be seen in RBC parameter? Hemoglobin, RBC number, MCV, RDW and hematocrit. What is hematocrit? Hematocrit, hemoglobin into 3 should be the hematocrit. What is the hematocrit here? Hematocrit here is 17, roughly around 17, right? And look at the platelet. Platelet here is 1.2 lakhs. And mean platelet volume, it was not mentioned here. Platelet here is, so platelet here is 1.2 lakhs. So this is how you need to interpret the automated hemogram printed sheet. But before interpreting, let me tell you the normal things. What are all the normal things? As far as the total count is concerned, total count normally should be 5000 to, what is the normal count? 5000 to, let me say 15,000 should be the normal count. An absolute neutrophil count less than 1500 is termed as neutropenia. An absolute neutrophil count more than 10,000 is called as neutrophilia. Whereas an absolute lymphocyte count more than 8,000 is called as absolute lymphocytosis. Whereas an absolute lymphocyte count of less than 3000 in first year is called lymphopenia. is called as lymphopenia, right? Lymphopenia. This is what you need to know with respect to WBC parameter. Now let's go to RBC parameter. What is the RBC normal number? RBC number is somewhere around 4 million. Your hemoglobin somewhere around 10 grams for all practical purposes. Hematocrit is should be somewhere around hemoglobin into 3. Hemoglobin into 3. That means hematocrit somewhere around here 30 hematocrit. What is called the rule of 3? What is called the rule of 3? Rule of 3 means, let me say RBC, let me say hemoglobin, let me write hematocrit. RBC into 3 should be the hemoglobin. Hemoglobin into 3 should be the hematocrit. This is called the rule of 3. Let me explain why it is so. Now, what is the normal mean corpuscular volume? 70 to 90. When it is less than 70, it is called microcytic anemia. It is called microcytic anemia. When it is more than 100, it is called macrocytic anemia. When it is 70 to 90, when it is 70 to 90, it is normocytic. It is normo. And then you have your normocytic. What is mean corpuscular hemoglobin concentration? It is somewhere around 30 plus or minus 2. Somewhere around 30 plus or minus 2. What is called RDW? RDW means red cell distribution width. RDW means red cell distribution width. RDW means red cell distribution width. It is nothing but anisocytosis. Nothing but anisocytosis. What is called anisocytosis? Anisocytosis means different sizes of RBC. Different sizes of RBC. In peripheral smear, you see different types of RBC. That is called anisocytosis. The same anisocytosis is nothing but red cell distribution within automated hemogram. The normal red cell distribution width is 15. Less than 15 means normal RDW. More than 15 means high RDW. Remember, high RDWs are always associated with nutritional anemias. I repeat, high RDWs are always associated with nutritional anemias. Okay? So now, what are all the parameters you can see? You need to know the normal value. Now let me go to the case scenario. Before going to the case scenario, so what we are going to see here, approach to anemia. The step 1. What is step 1 in anemia? Step 1 in what is called anemia? A hemoglobin of less than 10 grams per deciliter for practical purposes. What is step 1? Rule out other cell involvement. Rule out other cell line involvement. Cell line involvement. Why? So if hemoglobin is low, you need to look for total count, that is WBC, and you need to look for platelet. If total WBC is less than 4000, that is called leukopenia, and platelet less than 1.5 lakh means it is called thrombocytopenia. It is called as what? Thrombocytopenia. So whenever you have anemia, a hemoglobin of less than 10 grams per deciliter, you need to look for other cell line involvement. That is whether WBC is also affected, platelet is also affected. When other cell lines are involved, the causes are 1. Bone marrow infiltration. Bone marrow infiltration. 2. Bone marrow hypoplasia. Bone marrow hypoplasia. 3. It can be due to autoimmunity, autoimmune antibodies to your hemoglobin, platelets, as well as WBC. Fourth one is hypersplenism, spleen causing destruction. Hypersplenism. Bone marrow infiltration is nothing but acute lymphatic leukemia. Bone marrow hypoplasia means, for example, Fanconi. Autoimmunity, example, SLE. Hypersplenism means it can be due to anything. Usually, it can be due to storage disorder, or it can be due to undertreated thalassemia, in which spleen will destroy your RBC, WBC, and platelets. So, this is rule 1. Let us go to rule 2. Let us go to, so this is rule 1. Let us go to rule 2. Rule 2. What is rule 2? Rule 2 is look at RDW. So, less than 15 is normal, more than 15 is high RDW. High RDW is equal to increased anisocytosis. Anisocytosis. Always high RDW means it is nutritional anemia. It is nutritional anemia. Either it can be due to iron deficiency anemia, or it can be due to B12 deficiency, or it can be due to, second one is B12 deficiency, or it can be due to iron deficiency anemia, B12 deficiency, or it can be due to folate deficiency. Folate deficiency, RDW. First point. Second is look for MCV. Second is look for MCV. So it can be less than 70, or it can be more than 100, or it can be 70 to 100 femtoliters. Less than 70, microcytic anemia. More than 100, macrocytic anemia. 70 to 100, normocytic anemia. So this is rule 2. So apart from hemoglobin, you need to look for RDW, you need to look for MCV. And the final thing is rule 3. Rule 3. What is rule 3? In case of doubt, always do peripheral smear study. Always do peripheral smear study. In case if you have confusion over your automated hemogram. Confusion over your automated hemogram. Right? So with this background scenario, let's go to analyze some case scenario. Let's go to case scenario. Let's go to case scenario. Case number 1. So what is this case? Case number 1. What is this case? Look at this. This is a 3-year-old child. Fever, 3-year-old child. Fever is there. Limping gait is there. The child is having toxic look. Hepatomegaly, splenomegaly, lymphadenopathy is present. So what are all the things it was told to you? The hemoglobin is 7. Whenever you see a hemoglobin of less than 10 grams per deciliter, it is called anemia. Always you need to look for other cell line involvement. Other cell line involvement is platelet is reduced. So there must be some bone marrow involvement. MCV is 95. So this is normocytic. Total count is 70,000. How much? Total count is 70,000. Let me say neutrophil 10%, lymphocyte 90%. So an absolute lymphocyte count should be 90 by 100 into 70,000. So roughly 63,000 is the lymphocyte count. So what is the carry home message here? Carry home message. More than one cell line involvement. Cell line involvement. Second point, your total count is 70,000. Your absolute lymphocyte count is 63,000. 63,000. Along with that, the child is having toxic look, hepatosplenomegaly. As it was told to you already, whenever you see any case of more than one cell involvement, it is more in favor of bone marrow. What are all the four causes it was told to you? Look at this: acute lymphatic leukemia, Fanconi, SLE, storage disorder, thalassemia. If it is a case of SLE, SLE, is it a possibility? Yes, possible. Fanconi, is it a possibility? No. In case of bone marrow hypoplasia, hepatosplenomegaly will not be there. Can it be acute lymphatic and SLE? Can it be SLE? In SLE, you will get autoimmune mediated anemia, autoimmune mediated leukopenia, autoimmune mediated thrombocytopenia. But here your absolute lymphocyte count is high, so less likely. Can it be acute lymphatic leukemia? The answer is yes. The child is having fever, toxic look, pancytopenia. Along with that, there is absolute lymphocytosis. So this is the carry home. So more than one cell line involvement means bone marrow involvement. In total count is high, and if your lymphocyte count is very high, along with hepatosplenomegaly and lymphadenopathy, and the child is having toxic look, means invariably you need to think in terms of a bone marrow infiltration disorder such as acute lymphatic leukemia. Why that limping? Because of periosteal infiltration by the malignant cells. So case 1. Case 1 means more than one cell line involvement. What is the diagnosis? It probably this is a case of B cell ALL. Why ALL? Because absolute lymphocyte count is very very high. That's why it is B cell ALL. Case 1. Carry home is more than one cell involvement with hepatosplenomegaly, lymphadenopathy. Toxic look is bone marrow infiltration. Bone marrow hypoplasia will not be associated with hepatosplenomegaly, cannot be Fanconi. If it is SLE, means all cell lines will be reduced. Here white cell count is very high. So the answer is it is acute lymphatic leukemia. Case 2. Are you ready? Now case 2. 7-month-old child, exclusively breastfed, pallor is there, abdominal distance is there, liver is there, spleen is there, but no nodes. And let me say the child is non-toxic. So here 7-month-old child is presenting with anemia. 7-month-old child presenting with anemia. So what is rule 1? Associated platelet involvement. So platelet here is normal. Okay. But here the total count is very very high and the lymphocyte count is very very high. Is it a case of acute lymphatic leukemia? Look here also hemoglobin is low. Here also total count is high. Here also lymphocyte count is 85%. But here platelet count is normal. The child is non-toxic. Is this a case of bone marrow infiltration? Okay, if because there is liver is there, spleen is there, so can it be an acute lymphatic leukemia but the child is non-toxic? Can it be SLE? All cell lines are not reduced. Can it be bone marrow hypoplasia? Liver and spleen is against the diagnosis of bone marrow hypoplasia such as Fanconi's. So what is this? MCV is little bit on the lower side. So what is this? So step 1, not possible. What is step 2? Is it a microcytic hypochromic anemia? Yes. But is it iron deficiency anemia? It will not be associated with the liver and spleen. But you have so many lymphocytes. In these cases, what is rule 3? Go for smear study in case of any confusion. Smear study if you have any confusion. Here smear shows numerous nucleated RBC. Nucleated RBC, the size is equivalent to lymphocytes. You all know that Coulter counter, three-part counter is basically based on the size of the cells. If the size of the cell is this much, it can be due to RBC. The size of cell is somewhat between this to this femtoliter, then it will be calculated as lymphocyte. What happens in case of nucleated RBCs? The new size of the nucleated RBC is equivalent to the size of the lymphocyte. So it will be calculated as lymphocytes in a three-part counter. That's why spuriously high value. So this case is spuriously high. This case is spuriously high absolute lymphocyte count, and this can be clarified by doing a peripheral smear study which showed a nucleated RBC. Nucleated RBC, hepatosplenomegaly, is nothing but thalassemia major. So this is a case of thalassemia major. Thalassemia major is a microcytic anemia. In thalassemia major, hepatosplenomegaly will be there because there should be an extramedullary hematopoiesis because bone marrow is not working. And why this high total count? Because nucleated RBCs are pushed from the bone marrow, as a result of which you will get spuriously high absolute lymphocyte count. So what is case 2? Thalassemia major. What is the carry home message? Spuriously high lymphocyte count. What should you do? You do a peripheral smear study to look for blast or to look for nucleated RBCs. Nucleated RBCs will be counted as lymphocytes by automated hemogram. Okay, right. Case 3. What is case 3? 1 year old child. 1 year old child. What is case 3? 1 year old child, pallor 3 months. There is no hepatosplenomegaly, no lymphadenopathy. There are no blood transfusion, no fever, no toxemia. Toxemia. What is MCV? Hemoglobin is 4. What is rule 2? Rule 1 is look for other cell line involvement. Here total count is normal, platelet count is normal. So other cell lines are not involved. What is rule 1? Rule 1, other cell lines are not involved. 1. Second, what is rule 2? Look at the size of MCV. MCV is 50. So it is microcytic. So it is microcytic anemia, right? Microcytic anemia. Let me say, one second. So it is microcytic anemia. So rule 1 is, so MCV is less than 50. So microcytic anemia. Second point, RDW is high. RDW, red cell distribution, is high. 20. You need to look for CV rather than ST. Is 20 very high? Whenever you have MCV low, RDW low, RDW is high, hematocrit. What is the hematocrit? Hematocrit must be hemoglobin 4 means hematocrit 12. What is the RBC number? RBC number is just 1 million. So now you have rule of 3. When MCV is low, hematocrit is low, RBC is low. When all these three are proportionately decreased, when all these three are proportionately decreased means it is iron deficiency anemia. And as it was told to you already, in nutritional anemias, your RDW will be high. Normal RDW is 15. Here the RDW is 20. So rule of 3. RBCs are low, your hemoglobin is low, your hematocrit is low, along with the high RDW is iron deficiency anemia. So what is case 3? Iron deficiency anemia. What is case 2? Tall major. What is case 1? T cell leukemia. Case 1, case 2, and then case 3. Now case 4. 2-year-old Pallor on iron therapy, no hepatosplenomegaly, no bone marrow, no blood transfusion, weight is normal, height is normal. Hemoglobin is 8. MCV is low but not that much low. RDW is not high. RBC is 5 million. Other cell count are not decreased. So rule 1. What is rule 1? Other cell lines are normal. So no bone marrow involvement. Other cell lines are normal. Rule 2. What is MCV? So less than 70. So this is microcytic hypochromic anemia. So if it is microcytic hypochromic anemia, let's see whether rule of 3 is followed. What is rule of 3? MCV should be low, hematocrit should be low, RBC should be low. MCV is 65, little bit low. Hematocrit is not given here, rule out. What is RBC? RBC is 5 million. Look at this. When you have an anemia of hemoglobin of 8, when you have an hemoglobin of 8, your RBC should also be reduced. RBC number should also be reduced. When there is a disparity between hemoglobin and RBC number, it is not iron deficiency anemia. I repeat, iron deficiency anemia means proportionate decrease in RBC, proportionate decrease in hemoglobin. When hemoglobin is reduced but there is no reduction of RBC number, it is not iron deficiency anemia. So what is this case? Here your red cell distribution width is, I'm sorry, your red cell distribution width is, what is the red cell distribution width? RDW. Your red cell distribution is not high. So again it rules out iron deficiency anemia. So what is this case? This case is microcytic anemia, not responding to iron. Points against iron deficiency anemia are low RDW, no response to iron, as well as there is RBC number high. So this is a case of thalassemia trait. So this is a case of thalassemia trait. This is a case of thalassemia trait. So microcytic hypochromic anemia. This is a case of thalassemia trait. So generally speaking, there are two main things you need to know. Whenever you have a hemoglobin of less than 9 grams and your MCV of less than 70 femtoliter, always look for two things: RDW. So remember, high RDW more than 15 is more in favor of iron deficiency anemia, whereas low RDW less than 15 means it is more in case of thalassemia trait. Case of thalassemia trait, whereas one is over. Second one is look for RBC number. Look at this, RBC number is low, more in favor of iron deficiency anemia. RBC number is normal, means it is thalassemia trait. Thalassemia trait. So this is how you need to approach a case of microcytic hypochromic anemia. Very, very simple. Now let's go for case 5. 6-month-old child, irritable, no fever, liver not palpable, spleen not palpable, no blood transfusion given so far. Hemoglobin is 4. So this is anemia. Other cell line involved? Yes, other cell lines are involved. So rule 1. Rule 1. Other cell lines involved. Rule 1. What is rule 2? Look for MCV. What is the MCV? MCV is here is more than 100. So it is a case of macrocytic anemia. It is a case of macrocytic anemia. Remember, whenever you have a macrocytic anemia, Look again for red cell distribution width. When your red cell distribution width is high or normal, when your red cell distribution width is high, usually either it is B12 deficiency or it can be due to folate deficiency. B12 deficiency or folate deficiency, which one? So this is a case of macrocytic anemia. This is a case of macrocytic anemia with a high RDW, more in case of B12 and folate. Why pancytopenia? Then you can ask why pancytopenia? Because B12 and folate are required for DNA maturation, of all cell lines, of all cell lines. That's why you will get pancytopenia. That's why you will get pancytopenia in a case of B12 deficiency. Remember, what are all the other clues as it was taught to you? So this is a case of macrocytic megaloblastic anemia, more in favor of B12. What are all the other clinical clues you can have? You will have knuckle hyperpigmentation. You will have knuckle hyperpigmentation. Knuckle hyperpigmentation. One. Second one is in smear, you will get hypersegmented neutrophils. What? Hypersegmented neutrophils. Hypersegmented neutrophils means what? Usually you have hypersegmented neutrophils means more than 6 lobes per neutrophil. More than 6 lobes of neutrophils. Okay, usually neutrophils will have less than 4 lobes. If you have more than 4 lobes, if you have more than 6 lobes or more, then it is called hypersegmented neutrophil. That's why it is called megaloblastic. That's why it is called megaloblastic anemia. That's why it is called megaloblastic anemia. Remember, macrocytic megaloblastic anemia with a high RDW is always B12 deficiency or folate deficiency. Case 5. Then comes case 6. Case 7? What is this case 7? 7-year-old, pallor, fever, peticate. So pallor means hemoglobin is involved. Fever means WBC involved. Peticate means platelet is involved. No hepatosplenomegaly, no node, no bone blood transfusion so far. No blood transfusion so far. Let's see, hemoglobin is 2, platelet is low, total count is low. So this is a case of pancytopenia. But here MCV is 120. So this is macrocytic. But if it is a case of ALL, you will have hepatosplenomegaly. But here there is no hepatosplenomegaly. Remember, when you have pancytopenia without hepatosplenomegaly, that is more in favor of bone marrow hypoplasia. Bone marrow hypoplasia. That is more in favor of bone marrow hypoplasia. So probably this is a case of Fanconi anemia. Case of Fanconi anemia. Pancytopenia without hepatosplenomegaly with high MCV is inherited bone marrow failure syndrome. Case 7. And finally case 8. What is this case 8? So this is a 8-year-old child. with pallor along with spleen. Mild jaundice, no note. Here itself it shows it is hemolytic anemia because you have jaundice. And here, look at this, spleen is there. So it is destroyed in spleen. The hemoglobin is destroyed in spleen. So other cell lines, whether involved or not, TC is normal, platelet is normal. No other cell line involvement. No other cell line involvement. Hemoglobin MCV is 90. So this is normocytic anemia. MCV is 90. This is normocytic anemia. But look at this. MCHC is 40. MCHC is 40. That means what? High MCHC. So that means what? The mean corpuscular hemoglobin concentration is very high. Whenever you have high MCHC, that means the amount of hemoglobin per gram of RBC is very, very high. So in which condition you will get this very high MCHC around 40? It is a case of spirocytes. Most probably this is a case of hereditary spirocytosis. This is a case of hereditary spirocytosis. So anemia with the high MCHC is hereditary spirocytosis unless otherwise proved. Right? Unless otherwise proved. Right? Now summary. So what is the summary? So let me write summary. Point number 1. Low hemoglobin along with low RBC, and I'm sorry, I can't say low RBC, low platelet and low total count. In which condition you will get this? You will get this in acute lymphatic leukemia in which the child will be toxic. Along with hepatosplenomegaly, your lymphocyte count will be high. Another condition is autoimmunity, immunity such as SLE, in which also child will have toxemia, child will have hepatosplenomegaly, but your absolute lymphocyte count will be low. Third one is B12 deficiency, in which you will have MCV will be very high. MCV will be very high. Your RDW will be very high. Okay? Right. The next thing that we want to discuss is when you have MCV is less than 70, then look for RDW high, RDW normal. High RDW is iron deficiency anemia. Low RDW is tall trait. Tall trait. Okay. One more point that I forgot to mention in pancytopenia is, again, if you have pancytopenia with MCV normal or high along with no HSM, means it can be due to Fanconi anemia. That is that I failed to mention. So MCV low, and then you have MCV is low, and then you have normocytic. Normocytic means 70 to 100. What are all MCVs normocytic? It is usually hemolytic anemia. It is usually hemolytic anemia or non-hemolytic anemia, such as chronic renal. And then finally you have high MC. You have high MC. High MCV means two things. RDW high. B12 deficient, RDW normal, bone marrow hypoplasia. Thank you. Thanks for your patient listening. Bye bye. With this, we had completed our session on approach to anemia based on automated hemogram.